right, so we're here today with Marcus Herod. He's a anesthesiologist out in Virginia, and his wife is a doctor out there as well. We wanted to talk to him a little bit today about, what's going on in the front lines with the coronavirus, and it's good to talk to somebody like him that's actually like out on the front line. So thanks a lot for joining us, Marcus.
Yes, certainly.
All right, so we especially wanted to focus in on, there's been this discussion about how coronavirus is really hitting the Black community much harder, especially with regards to deaths and severe illness. So we kind of wanted to get your take on some of that. And what we wanted to start with is the Surgeon General. I don't know if you saw his press conference, how was it, a week ago or 2 weeks ago, where he talked about how it was affecting the Black community more, which was a good conversation that, something that the country really needs to have. But then towards the end of it, he said something, I don't remember exactly. If you remember, you can chime in,
yeah,
John.
He
something
said,
like their
do it
behavior,
for Big
right?
Mama. Yeah, do it for Big Mama. Do it for, it was real.
Abuelo.
Yeah,
Right.
yeah.
But then he was saying, like, the Black community has this behavior that they need to change with, like, I don't know, I don't remember if he was like, in fact, I don't know if I actually saw the whole interview, just what people have said about it. It was like, drinking and smoking and all this stuff.
Yeah.
So I wanted to get your thoughts on that. Do you think that?
Sure. So Jerome Adams, the Surgeon General, Jerome Adams and I actually go back a few years. He was my mentor in medical school. We both graduated from the same medical school. We were both anesthesiologists. He actually mentored me in going into the profession of anesthesia while I was a medical student at Indiana University. So I know him a little bit more personally than most people might. So I did hear the comments that Jerome Adams made about make sure Abuelo, if you want to take care of Abuelo, if you want to, take care of Big Mama, I think he was trying to be a little bit more common with people and use language that kind of people understand. Jerome is, he's a well-spoken guy. He's someone that really means well in what he's saying. And I think he was just trying to broadly apply to people that from different backgrounds. Now, as it pertains to some of the behavioral issues that he meant to sort of minimize, i.e. drinking alcohol, smoking, all those kinds of risk reduction strategies that people use that are sort of generally done in sort of a primary care setting. I think that, I certainly back what he said, right? We need, in our communities, not only in our communities, but in the white communities, in the Asian communities, in the Hispanic communities, we all need to stop those kind of, those behaviors. Wanton alcohol consumption leads to things like diabetes, hypertension, all are risk factors for, severe illness in COVID-19. So while I think that, given where he's standing and who he's standing next to, I think it may have been received a little bit more negatively than what he really tried to make or tried to say to others.
Yeah.
So do you think that in this, I understand what you're saying, like anybody associated with the Trump administration, that's kind of people, to be perfectly honest. I don't know how many Stephen Millers there are around him. I don't think he is, but there's definitely the sense that, like, why did he bring up these behavioral issues when he was talking about Black Americans, right? Because, obviously, rates of drug use are higher among white Americans, right? So I think that was the big issue that people took, right? But I think that's a good point about, who he's standing next to, the context of the situation. But I do think the context is important too,
Yeah, I do too, and I think that from my perspective and the people that I talked to, it really wasn't a matter of, I can't believe he said that, but it was is that really the problem? Like it really, like for me, it didn't feel like that was the issue. Like the real issue is, the lack of healthcare and the disparity that was already existing, and he didn't touch on that. So and I understand that might not have been what was the point of the conversation at the time, you know what I'm saying? But I was hoping that he would come back and say, hey, you know, we do understand these things and trying to figure it out. So Marcus, like from your personal experience with him, do you think that would be something that, is he thinking about this stuff, or is it just, you know, he's trying to move on? Do you think that he understands that, or?
Oh, so let me tell you, at IU, it was, we all worked in, so in medical school, we had a program where we'd go into, you know, underprivileged communities, underprivileged areas in Indianapolis. We'd build houses, we'd tend gardens, we'd meet with kids, and Jerome Adams was just as invested in that as we were. So he was actually one of the mentors that put people in those areas to sort of give back to the community. A little bit to his background. So he was the Surgeon General of, he was the Surgeon General equivalent for the state of Indiana. They had a very bad heroin use problem, and the heroin use was throughout. Blacks, whites, everybody was using it, and they had an IV drug use problem. And under his administration, where he worked with Mike Pence, they sharply reduced the amount of drug rates there, and sharply reduced the amount of HIV spread through various programs. So do I think he has a perspective of underrepresented minority communities? 100%, absolutely.
Yeah. Okay, fantastic. Fair enough. Yeah.
Yeah, I was going to say, I mean, it's interesting though, because you hear a lot of criticism from, there was a study that came out a few years ago. I think it was a couple of studies that talked about how even within the medical profession, there's a lot of misconceptions about race and race biology and genetics and things like this. Like a lot of medical professionals actually believed that Black physiology was different than white physiology, for example. And I don't think he's probably among those, but it is like, there is a common problem even within people who are, you know, they should know a lot about biology, anatomy, physiology, things like this, that they have this sense that there are actually innate differences between the races. So I think that's kind of an interesting issue that you do have in the medical community, which I don't think is like really addressed enough, to be perfectly honest. I mean, you hear activists talking about it, but you don't really, I don't know, what's your sense? Do you feel like the medical community has really like been proactive about dealing with some of these misconceptions?
So it's hard because there are subtle differences between, you know, African Americans, Caucasians, Asians. There are certain things that people have that make them more susceptible to certain medications and or make them a little bit have different effects. So there is a sort of ethnic, racial perspective to how we practice medicine. For instance, there's certain hypertension, for example, has kind of a different origin in African American people versus the origin in Caucasian people. And that's why, you know, certain medications work a little bit better in African Americans versus, you know, Caucasians. So there are subtle differences in physiology. I mean, yes, we all have hearts, we all have lungs, we all have livers, we all have kidneys, right? But there are little differences that have kind of adapted over time that make people either susceptible to certain illnesses and or, you know, make them susceptible or not susceptible to certain medications.
Yeah.
Right. I mean, I guess we're bumping up against my sociology background. That's like, I tend to like focus on environmental, you know, external to the human, whereas medical professionals tend to focus on
me too,
the, you know, internal to the human. So, but I do know that, you know, I've heard plenty of this about, you know, like, I mean, obviously, like sickle cell anemia, for example, is much higher among like the African American, but also, you know, among Mediterranean whites.
Correct. Yeah, thalassemia.
Things like this. So it's, you know, these aren't like 100% in any of these populations, right?
You're right. You're absolutely right. Absolutely right.
But it is interesting hearing that perspective. So this kind of brings us into what we're wanting to get into specifically. So, like, what have you seen on the front lines with regards to, you know, race and COVID-19 where you are? Have you noticed any sort of like patterns Isn't this
So
where you are?
yeah, so let's back up. So Virginia really is essentially two states, right? Virginia
Yeah.
is more so you have your kind of northern Virginia, really, I guess three states essentially. You've got your sort of DC area where you're northern Virginia, that's heavily it's interspersed with African Americans, Caucasians, Asians. It's a really multicultural area. Then you have your more rural Virginia that
Right.
kind of extends between that and I would say Norfolk, Virginia, where I live. I'm in Hampton Roads, essentially. And our communities are a little bit different. Like Hampton Roads essentially is 4 or 5 smaller communities that band together and they call themselves sort of Hampton Roads, right? You've got Norfolk, you've got Suffolk, where I live, you've got Virginia Beach, you've got Newport News, and you have Hampton, which is where my wife works. And those areas are kind of different because there's not like a lot of public transportation. There's no subway system here. There's a large military community here. And I think when you combine all those factors, essentially you don't have a lot of spread of disease within the area because we all live in sort of separate like cities, if you get what I'm saying.
Right.
So what I have seen, I've seen patients of all different ethnic types with COVID-19. I will say, and my wife actually pulled the statistics last night, there is a higher incidence of patients that have died that were Caucasian in this area. And so, and it follows sort of, the vast majority of people that have passed away in this area are of Caucasian descent. And then it really just follows kind of population-based statistics in this area. This is very different than Chicago, right. New Orleans, New York City, totally different area.
Now, were you talking about the raw numbers or the rate there?
The rate. So she pulled it up based on ethnicity, and it follows I think it's like 40-50% Caucasians have died of COVID-19 here, and then I'd say 20% African American, 15% Hispanic. The numbers don't add up perfectly, but that's the gist of what I've seen personally and what my wife has seen out in the community.
Yeah,
because we know here it's the Latinos and Blacks are overrepresented in the numbers of people getting coronavirus. Not by a huge amount, but they are overrepresented, and whites are underrepresented in that number. That's interesting out there. I mean, it's interesting to think of the geography of the place. I'm trying to think if there's what's the name of the university out there? It's like
there's Hampton University. There's Old Dominion University.
Okay, there's another one. It's like maybe it's not. Maybe I'm thinking of the wrong place. I went out there for a conference. It was an odd place.
Okay.
So
Marcus,
I just wanted to add one thing that in Hampton Roads, you have like a large affluent African American population. You have a larger more affluent Hispanic population than you do in sort of most other areas, especially where I live in Suffolk. It's like probably I wouldn't say predominantly, but probably 40 to 50% African American. And all of us are sort of, upper middle class. It's an upper middle class area. And you don't see the same numbers as you were in Chicago, where you have a lot of African Americans that are in, cramped conditions, live in, small, multi-story buildings. Everybody's putting their hands on the elevator. So it's a different environment. It's like comparing sort of apples to oranges.
Right. I mean, and it's interesting to consider the class, the convergence of class and race in that context, I think is important.
Yeah.
And sort of, and COVID-19, the interesting thing about it is initially it was a disease of affluence. If you think back a few months ago, who were the first people to really come out and talk about having COVID-19 illness? It was the movie
actors,
stars. It was
people
Tom
traveling.
Hanks. It was all the people that are traveling and have really high interpersonal interactions. And so you know, right as of now, you're seeing, you know, people in areas that are cramped, people that live on top of each other, people that are sort of in first responder type jobs that are actually contracting the
Yeah.
illness.
Yeah.
Yeah. People that
It's
are
like a
like,
cycle for sure. And
yeah.
what's helpful for me, like for my mental anyway, is that it's been fast. It feels like it hasn't taken a long time for it to go from all the way where it was or where it was looking like it was headed to like, okay, it looks like it might be trying to settle down a little bit. And that kind of brings me, if you don't mind, John, I'll ask him this next one. What concerns you the most when dealing with the virus from a social perspective, when we're talking about the beaches in Florida opening, and the president basically saying that, hey, we're gonna, if they want to open up after the first and they can, more than likely that means that they're going to, right? So what from the medical profession, what concerns you the most with that?
So the big thing that concerns me with opening up the beaches is just making sure people are adhering to social distancing policies, right? 6 feet away from everybody. You know, make sure everybody is washing their hands. You know, just basic sort of best
The stuff
practices
we've all
right
been
now.
hearing, yeah.
Yeah, and the other thing is, and Sean, I really want to touch on this, is there's a lot of fear out there. There's a lot of fear on the news. And it's something that I think that is not even, it's even infected the medical profession. There is a lot of fear of not having masks, fear of not having equipment, fear of, and you see that being pushed. And I haven't been in a situation, nor has my wife been in a situation where we haven't had the appropriate personal protective equipment.
Yeah. I was just talking to one of our mutual friends, Ricky Moody, and he was saying the same thing. He recruits people in the medical field, and he was saying the same thing. Like, man, the big thing is like sending people to a job and they don't have the stuff and they don't want to work anymore. Once they get there, he's like, that's what they're dealing with now. He recruits nurses for nationwide or whatnot, and yeah, man, he that's exactly what he told me. He was like, man, people are just kind of shook right now, and it's trickling into the medical profession. So it's kind of validating other people's fears, So it's like
Yeah.
one side eating itself at it from the other end. Yeah.
And so go ahead.
Well, I was gonna say, how much of that do you think is because like New York City just got hit so hard so quickly? Are we using that as our normative model? For like, well, if that happens everywhere, that's that's basically the worst case scenario.
Yeah.
So I think that's exactly what's kind of being pushed. We saw those videos from Italy, and we thought, oh my God, what if that happens here?
Yeah.
And it went into New York City, and New York is a sort of, people are stacked on top of each other. If it spreads like wildfire, it's going to spread in a place like New York. Everybody's on the subway. It's cramped. I mean, there's a different lifestyle that exists in New York City, and it hit the entire area hard, right? Now the numbers are starting to come down, but they had enough ventilators. They had enough personal, there's been some stories about limited personal protective equipment. I can't speak to that. All I can speak to the environment that I work in and my wife works in, and we have had no issues when it comes to personal protective equipment.
Yeah, that's good, man. I heard stories about New York getting price gouged and stuff. The hospitals trying to reach out, and they were just, paying astronomical prices to get their hands on something. Yeah. Yeah, my bad, John. Go ahead, brother.
No, that's okay. Actually, so that raised a question for me. It's something me and my wife have been wondering about, and it's been talked about in the news a little bit lately. Like, well, what happens when this hits these rural communities that you were just talking about? A lot of these, like southern Indiana, southern Ohio, Appalachia. What happens when it really hits there? They've already been struggling with like this opioid crisis, and you hear about these rural communities that really don't have the resources to deal with a lot of this. Like, do you have any thoughts on that or any experience with that at all? Or
so I would guess that you would look at your larger regional sort of referral centers, and those regional referral centers would be able to grab patients or have patients transferred into those areas. And this is more of my wife's specialty. If you have COVID-19 patients, if they're critical, they may need to be sent to a Duke or sent to a Norfolk General or sent to a, regional referral center. So I think that the challenge is triaging and assessing, testing, ensuring that these patients have the illness, and then getting them to sort of a referral center that knows how to take care of the patient.
Right.
So I think that kind of will be the key, getting the hospitals to communicate with one another, getting areas to think of themselves in terms of a group versus thinking of themselves as sort of an individual hospital, and we
Right.
can handle all this within our environment. No, the model of medicine is, at centers of excellence. And there are places that have established
Right.
themselves as centers of excellence.
Right.
Okay.
So do you guys have enough tests where you are?
So we haven't had any issues with testing. I know that the certain hospitals have different policies as to who they test. So initially, if you show up to the hospital and you have, you have an upper respiratory infection, but you're stable, your vital signs are stable, you're not hypoxic, you're not, your oxygen levels are normal, your blood pressure is normal, then really the treatment is supportive at that point, right? And that can be done at home. So whether you have a positive test or a negative test, you're still going home and you're going to be treated, supportively.
Yeah.
The people that are getting admitted to the hospital, everybody that gets admitted to the hospital that has an upper respiratory infection gets a COVID-19 test.
Okay.
Now, certain places have, I know that some of the hospitals I've seen have sort of rapid turnaround tests that can be back in 24 hours. Some of the private practice hospitals have turnover times in the 30, 45-minute range. So it really depends on whether you're admitted or you're not admitted. Now, I imagine as testing gets a little bit more, they get more tests, and I would say that probably within the next week or two, everybody ostensibly will be tested that comes in with an upper respiratory infection for COVID-19, and that's really to protect so that they can, tell their employers if they're in an essential position that, hey, I tested positive for COVID-19, I can't go. Now, I do think as the economy opens up and we go back to sort of, phase one, we're back in kind of phase one of recovery, testing is definitely going to have to speed up. We're going to have a lot of testing. We're going to have antibody testing because there's a large amount of people in the population that have had COVID-19 and were asymptomatic.
Right.
There's the vast majority of people that get COVID-19 are asymptomatic.
Okay.
Sneaky that way, yeah.
Yeah, it is crazy, man. So Marcus, as we talk about testing real quick and not to get too long with it, I just wanted to, nationally, I know that doctors share information through articles and, different research, and different things like this. Is there any literature being passed around about plans to test the communities that are hit the hardest, i.e. the Black communities in some of these cities and places where, just the term drive-up testing, it excludes a lot of people right off the bat, so there's a lot of folks that won't be able to get to these tests once they are available.
Exactly.
Here in the Springs, we have, I know of 2 drive-up testing facilities, but they can't, from the neighborhood that you and I are from, we can't get there if they don't have a car, so I'm wondering, is that a conversation amongst, the profession in general, or where can the layman look for this stuff and try to figure it out?
So I think that as we get back to sort of business as usual, what we need more comprehensive, cheap testing, right? We need to get the grocery stores involved. We need to get the pharmacies involved.
Yeah.
We need to get everything, all these small areas, a parking lot, right? Like, Sean, we grew up around the area. There were plenty of grocery stores in that area, plenty of 7-Elevens. It's going to take that level of sophistication in order to get everyone tested, which eventually we're going to get to that point where we're testing everybody. Right now, I mean, I get it. It's an imperfect system, and areas are doing the best they can with the resources they have. But at some point, the COVID-19 testing will be so spread out that everyone involved, Black, white, Latino, will have very easy access to getting testing. And then the question is once you start testing people, you're going to have to do contact tracing. I mean, there's a huge plan that goes into it's not just testing everyone. It's isolating people that are around certain contacts. It's quarantining them. It's antibody testing. So there's a huge system that needs time to set up.
Yeah. I mean, that's what they've been doing in Singapore, basically, right? I mean, every single person, they're tracing those contacts. And
yeah, I saw in the Philippines that the Filipino leadership said, hey, they're going to start shooting people if they're out in the street. He told the police, shoot them dead. Yeah. Hey, man, so I think that pretty much covers all of our questions. And hey, Marcus, I really appreciate it, man. We kind of referenced that we grew up here together. I don't think that we talked about for the audience. Marcus Harrod is a graduate of Harrison High School in District 2 down in Colorado Springs, and we went to school together, man. So and now he's obviously being mentored by the Surgeon General of the United States of America, man. It's pretty awesome, man. So every time I think about this guy, it's like, dang, man, I feel like like a sense of pride, like I had something to do with it when I really didn't. I just knew him since we were kids or whatever. But man,
I'm sure you had something, John.
Yeah, man, I'm really proud of this guy, man. He's a really good friend of mine, and I appreciate you taking time, Marcus. Man, I love you, brother.
Yeah, cool. Hey, one other thing I'd like to just say in sort of closing. I think that a lot of what COVID-19 has shown us, especially through social media, is it's really a lens, right? It's a lens into what do we fear the most? What are we concerned about the most? I see that, Sean is, he's really active in the community, and he posts a lot about kind of being active in the community and really looking out. So really his angle has been towards minorities and making sure people that are underrepresented or poor actually get a shot at sort of having a voice. You look at others and, you have highly intelligent people that are trying to make sense of it, which it's too challenging to make sense of. I'm an anesthesiologist. I'm a fully trained medical professional, and some of it's even more difficult for me to fully make sense of. Yeah. So right now, it's been kind of like a lens into who people are. If they're fear-based, you hear a lot of fear. If they're looking to grow the community, then you're going to see a lot about that in their sort of social media. So I would just say use it as a lens to look into yourself and figure out where you stand on this, and how can you make your community, how can you make your environment better? So.
Hell yeah. All right, that sounds good. Indeed. Thanks, man. Appreciate it, brother.
All right. Thanks a lot.
All right, man. I'll holler at you, man. Y'all be good, man.
All right, you too. Bye.
Yeah. Bye-bye. We got your boy.